Okay, good evening, ladies and gentlemen. It's a pleasure to be here tonight with you once again from Cardiovascular Innovations Foundation. This is our series of Interventional Octagon, and tonight we are going to be sharing 4 wonderful cases with good discussion around the peripheral and endovascular intervention. The theme for tonight is extreme CLI and no option patients, and we look forward to these presentations. Some housekeeping slides that I'm going to go over. This is a CME event, as you know. The learning objectives are highlighted here. I think tonight, obviously, we're going to see a lot of retrograde and pedal and all kinds of access. You're going to see some technical dexterity and interventions related to deep venous arterialization. And obviously, anytime you're talking about CLI, there will be discussions around wound management and limb salvage. So stay tuned for some great cases. Mehdi Shishehbor, interventional cardiologist from University Hospitals Harrington Heart and Vascular Institute in Cleveland, Ohio. I'm joined by my partner and co-founder, Dr. Subhash Banerjee from Baylor Scott and White Heart and Vascular Hospital in Dallas, Texas. We have two colleagues, panelists with us tonight. Dr. June Lee from University Hospitals Harrington Heart and Vascular Institute in Cleveland, Ohio. And we have Dr. Javier Vasquez from Texas A&M University Medical Center, Baylor Scott and White Heart and Vascular Hospital in Dallas, Texas. We had a number of cases that were submitted for this competition, the Interventional Octagon. It was a very difficult decision, to be honest with you. And I'm proud to announce the 4 winners for tonight that are going to be presenting. Dr. Hector Adamchick from Baylor University Medical Center in Dallas, Texas. Dr. Ekramul Gofur from Miami Cardiac and Vascular Institute, Baptist Health in Miami, Florida. Dr. Gordon Wong, Endovascular Fellow, University Hospitals Harrington Heart and Vascular Institute, Cleveland, Ohio. And Dr. Ahmad Younes, interventional cardiologist from ProMedica in Toledo, Ohio. These are the conflict of interest of the moderators and the panelists. And again, these will be all uploaded to our website for those that want to get the details. I want to acknowledge tonight those organizations that have supported CVI, Abbott Laboratories, Boston Scientific, Cordis Corporation, and Medtronic for their commitment. This is a CME event. Again, please know and take a picture of this. And again, this will be on our website at cvinnovations.org. But you can get CME credit for this activity tonight. We are very proud of our, obviously, national meeting. Please do not forget to mark your calendar for August 6th to 8th, 2026 in Denver, Colorado. Cardiovascular Innovations and National and International meeting to be held. And I think this next year is going to be as fun and funner, hopefully, than the prior year. So with that, remember that all of these Octagon and the national meetings are archived on our website, www.cvinnovations.org. Please use the QR code or just visit the website and you can see all of these. This is free education. We obviously believe in education. We know that the future of medicine is all about education, and we hope that you take advantage of these webinars and interactive sessions. So with that, I'm going to hand it to my partner, Dr. Banerjee, to introduce the first presenter, and we take it from there. Thank you so much.
Thank you, Mehdi. That was an awesome introduction. Let me get straight into business. There will be 4 case presentations, 15 minutes allotted to each participant, 5 minutes for questions, 10 to 11 minutes for their presentations, and the 4 judges will rate them from a score of 0 to 10. And the results will be announced by my partner and colleague and friend, Mehdi, at the end of this presentation. I just want to add, Mehdi, that the first prize award is $500 for this competition. However, everyone today presenting is a winner. It'll be difficult and challenging, but all the presenters will be invited for a scholarship and award to travel awards to CVI next year with funded travel, hotel, registration, and lodging. So let me invite Dr. Hector Elizondo Adamchick to present from Baylor University Medical Center, an option for no option CLTI patients, deep vein arterialization. So over to you, share your screen, and the timer will be on soon.
All righty. Thank you for introducing me, Dr. Banerjee. Let me put this in presenter mode real quick. There we go. Can everyone see my slides?
You are
All
good.
righty.
Begin.
So as Dr. Banerjee said, I'm Dr. Hector Elizondo Adamchick, vascular surgery fellow from Baylor Scott and White in Dallas, Texas. I have nothing to disclose. So this case is a 65-year-old male who came in with left toe pain. He had ulceration. He had purulent discharge and decreased ABIs. He didn't have any systemic signs of infection. Past medical history, he had chronic kidney disease, diabetes, hypertension, hyperlipidemia, and he had CAD, status post-CABG. He additionally had undergone a left lower extremity angiogram with an angioplasty of the posterior tibial artery about a week and a half prior to presentation. So our initial clinical challenge, this gentleman had a non-healing wound of the first toe. He had severe inframalleolar disease with a desert foot, as you can see on the angiogram there. And he had a high max score, which put him at a high risk for major amputation. So how we did this is we did a deep venous arterialization. So we started by prepping both groins, the entire leg. We started with getting access to the lateral plantar vein with a radial access kit. We started with an 014 starter wire, which was then exchanged for a glide wire and a 5-French sheath. After that, we got access at the common femoral artery on the ipsilateral limb, and we did an antegrade. We did a diagnostic angiogram and cannulated the donor artery, which in this case was the peroneal artery. You can see the posterior tibial artery there, which is still open, but you don't typically want to get a vessel that's open. We systemically heparinize the patient for an ACT goal of 250 to 300. After that, we traverse the vein or the venous plexus all the way to the proximal posterior tibial vein. And you can see our wire and our catheter on the arterial side and the venogram showing the posterior tibial vein there. Trying to advance. There we go. So after that, we did a diagnostic angiogram simultaneously between the venous and the arterial side. We got an idea of where everything was, and we did multiple views to confirm that our lymph flow arc system and the V-seaver, which is a recipient of the wire, were next to each other. So we crossed over using a Viper wire and then snared it with the V-seaver from the venous side, pulled it all the way from the venous side by pushing on the arterial side, and then externalized the wire at that site. We then ballooned the tract with a 3mm balloon. I'm going to pause this here. So this is exactly where the crossover was, and you can see the peroneal vein or peroneal artery crossing over to the peroneal vein there. So that we ballooned with a 3mm balloon, and we followed that by angioplasty of the entire posterior tibial vein with a 5mm serenator, basically to prepare the vein. After that, we placed 3 stents, starting at the most distal aspect, basically at the lateral plantar vein, and going all the way up to the artery. So we did that with a 5x200mm lymph flow stent to start with, followed by a 5x150, and then finally we used a tapered 3.56x60mm stent to the artery side. After that, we post-dilated the venous side with a 5mm balloon, just plain old balloon. and then came back to the lateral plantar vein and ballooned that segment while simultaneously retrieving the venous sheath and the wire, basically to create hemostasis of our venous access site. We held that balloon for 4 minutes. We then accessed the stent from above, which, oh, 1 second. So we accessed the stent from above, so from the arterial side, and we went to the venous loop and we ballooned that open, 1 for valve disruption and 2 to improve blood flow to the forefoot. After that, we showed our completion angiogram, which you can see here. Let me pause it at a better spot. It's not going, but basically you can start to see some of the metatarsals there, which supply the forefoot there. And then this is a slide with just a comparison between our pre-op angiogram and then our final shot, which is a much more robust blood flow to the foot. So I put all of the steps for a deep venous arterialization here, but I wanted to highlight 2 things that were more challenging during the case. So first was the ultrasound guided access of the vein, and the second one was the crossover to the venous side. So first, accessing the lateral plantar vein can be technically challenging, and that is usually because the veins are pretty small and they're prone to vasospasm as well. So one thing that we did that really helped us was putting an elastic tourniquet on the ankle, allowing the veins to dilate some. Even with that, we didn't have great dilation. So in addition to that, we did a lap pad with some warm saline, and we wrapped the foot around it for a couple of minutes, and that also helped. We struggled for a good amount of time, but after those things, we were able to get the access. And then I wrote down bear hugger. I think that should be standard of care for doing this procedure. That's another adjunct. Now, we also encountered some issues with tracking of the wire to the vein that we wanted. So one thing that can be done is do a cocktail of nitroglycerine, verapamil, and heparinase saline. We didn't really do this, but we did re-stick it because we were unable to track it, and that we just did it at a more proximal side of the same vein, and that helped us track the wire a little bit better. And then hockey stick probe. I think using this probe is better because it adapts to the contour of the foot, and it reduces the artifact and shadowing, which makes it a lot easier to see the tip of your needle. Additionally, the hockey stick probe is smaller and it's not as heavy, so it's easier to manipulate and really get a good view of the vein. And then the second thing, as I said, is crossing over to the venous side. Obviously, selecting the correct vein can be difficult, as we encountered some issues there. And then it's important to remember that because it looks great on one view, it doesn't mean that they're actually close together. So you have to really get a multiplanar view of your vessels and really confirm that you're next to each other. The worst thing you can do is try to poke a bunch of times in the artery and then cause a bunch of bleeding. So very important to really get a good look at it before you poke. Another one of the challenges that is not so much for the case, I think, is patient selection. You got to really ask yourself if the patient is too far gone to rescue. And some patients will come in with terrible wounds and they're not really, they're not willing to really undergo any further revascularization, and that's okay too. In addition to this, obtaining a preoperative echo is very important. You got to make sure that their EF is acceptable, and we really don't do a lot of DVAs on patients that have an EF of less than 30. And the reason is there's a high risk for high output heart failure, and you want to avoid that. And then as far as imaging preoperatively, you want to obtain plain films to review the MAC score. And then you want to get venous mapping to really evaluate the superficial and deep systems and ensure that the lateral plantar vein is intact, especially these guys come in with wounds. The wounds itself, can scar down the vein some, so it's important to ensure that it's patent. I put this slide here to kind of review some of the venous anatomy. There's the superficial system and the deep system, which are both acceptable as venous arterialization conduits. But if you're looking for a good vein to stick and you're trying to do a deep vein arterialization, you got to follow the veins and make sure they're draining to the appropriate vein. So the medial marginal and the lateral marginal are more superficial and they drain to the greater saphenous and the small saphenous veins. And then the deeper veins are the medial plantar and the lateral plantar. They form a loop and they both drain into the posterior tibial vein. So you got to really follow those and ensure that they're going to the correct conduit. Some of the postoperative challenges, it will get worse before it gets better, and that's important. For the patient, the family, and even your peers to understand that edema can be pretty severe. And, if we did this open, the wounds could break down easily. That's why we do it more percutaneously now. You got to monitor the flow volumes postoperatively. Your goal is 50 to 250. And even more so, people are describing 80 to 100 milliliters per minute. And then finally, just some closing remarks for doing a successful DVA. I think access defines success. So you got to prioritize ultrasound guided access. And then you got to manage the vasospasm proactively. As we said, warmth, nitro, verapamil, use of tourniquet. Those are all things that are going to help you. So you got to prepare to have some vasospasm. Precision with imaging, use multiplanar views and really ensure that the vein and the artery are close to each other. Conduit optimization, you gotta disrupt the valves and really prepare your conduit that you're gonna stent. And it's important to really stent below the lacinatum ligament, which is a natural point of pressure that if you don't stent below that, your DVA might fail. And then finally, just important to do postoperative surveillance and really keep track of your inflow, your outflow, and your conduit. Thank you very much.
Thank you, Hector. I'll let June and Mehdi get on with the questions because we are familiar with Hector's. Go ahead, please. I have a great job.
I just have one comment for Dr. Shishehbor with your vast experience. Any comments on the use of the peroneal as the donor vessel here?
Yeah, I think they did a good job, Hector and his team, they did a good job of making sure to preserve the PT because, in these patients, you get steal phenomenon if you take out the flow, the native flow to the artery. And I think some of the pictures he showed us probably were not aligned because the picture he showed with the receiver and the arc were not actually the picture where they actually crossed the peroneal. So those were not aligned pictures. Maybe they were different patients, I don't know, but they were not the same picture, the same patient. So it was nice that they were able to find the right vein and cross because there's no way you can cross in that first image. Those are too far from each other, and you wouldn't be able to cross at that level that far from each other. But the question I was going to ask you, Hector, was that what did you guys do from a standpoint of the wound and what happened to the patient in regards to the timing of the amputation? What kind of amputation did you suggest, and what kind of recommendation did you make to the podiatrist from the standpoint of the toe and the foot related to the DVA?
Yeah, so fortunately for us, we have a podiatry team that's very involved and is very aware of the venous arterialization. So it was easy to talk to them and let them know, hey, we did this arterialization. Let's see what the wound does. This procedure is not very old. It was relatively recently. The patient has not had an amputation yet. He hasn't had further drainage. He's recovering well. His swelling actually is resolving now. And again, we haven't done any amputation for him. We've basically just been doing localized wound care with no further debridements.
What kind of recommendation would you make to them? What would be your, remember, this is a competition, so I gotta ask you some tough questions. So what kind of recommendation would you make to them? Because they're not going to be used to this. Let's imagine that they have never seen a patient with DVA. What kind of advice would you give them related to the DVA that you just did this beautiful case?
So one thing is, I would say, let us know if you're trying to do an amputation if this goes wrong, because the circulation is going to be completely different. I think it's important to look at, what level of amputation and even possibly plan for a level of amputation with your DVA. So there's other things you can do like coiling and, kind of knocking out veins that will get amputated, so to speak. And I think that's important to communicate with your podiatrist. Specifically, I would recommend just continuing a betadine paint and then wrapping it and seeing how it progresses. If it's putting out a bunch of pus, the patient's getting sick from it, then we might just need to do an amputation. But if that's not happening, I would urge them to be patient and just continue watching it.
I think what Dr. Shishehbor is trying to allude to is that if there has been any pre-planned debridement, that those should be deferred for a certain period of time and should probably not be carried out immediately after DVA. So I think that's one of the important recommendations sometimes that can actually foil what a DVA procedure is trying to achieve. So I'll leave it there. And I think in the interest of time, great job, Hector. And we will move on to our next presenter. Dr. Ekramul Gofur from Miami Cardiac and Vascular Institute, Baptist Health. And the topic of presentation is persistent CLTI despite multiple interventions. So, Dr. Gofur, please share your screen and the floor is yours.
Thank you very much. My name is Ekramul Gofur. I'm a fellow at Miami Cardiac and Vascular Institute. Pleasure to be here. Thank you for having me. This is a case of persistent CLTI despite multiple interventions. This is a case I did with my attending. No disclosures. So we have a 90-year-old male. He presents with chronic limb-threatening ischemia to the left foot. Pertinent medical history. He has AFib with a pacemaker, insulin-dependent type 2 diabetes, peripheral vascular disease with chronic left foot ulcer, and importantly, no smoking history. On physical exam, he has eschar and gangrenous wounds to the heel and metatarsals, no PT or AT Doppler signals to the left foot. He had his initial angiography in January of 2025, where the perineal artery was recanalized, but the wounds didn't heal properly. We brought him back in April of 2025, where we saw reocclusion of the perineal artery, which at that time was successfully opened, but we failed to recanalize the posterior tibial and anterior tibial at that time. We subsequently brought the patient back in July of 2025. We started with a left antegrade access. We did a left lower extremity angiogram, and at this point we see moderate segment reocclusion of the perineal artery and persistent proximal occlusion of the anterior and posterior tibial, similar to what we saw before. At this point, we decided to proceed with an off-shelf deep vein arterialization, DVA, of the foot. And so our first clinical challenge in this case is to determine, what's the ideal donor artery, in this case for the DVA. We had recurrent occlusion of the perineal, and the proximal AT and PT were both occluded. So we began the case by at least trying to preserve the flow to the foot by the main artery that was keeping flow, which in this case was the perineal artery. We were able to cross the moderate segment occlusion. And at this point, we decided to use 2 drug-eluting coronary stents to keep the perineal open. This is the 3rd time the perineal is reoccluded. So we really tried our hardest at this point to kind of keep inline flow to the foot. Our second step was to prepare the donor artery. We decided to proceed with the posterior tibial artery due to favorable anatomy between the artery and the vein. We were able to successfully recanalize the PT. We crossed with the 018 catheter wire and angioplasty with a 2.5 millimeter balloon. And our method in trying to create that AV connection, we got posterior tibial vein access. And in this case, we brought a reentry device through the arterial end and a high pressure balloon through the venous end. Our goal was to try and puncture the balloon with the reentry device needle. The reentry device also allowed IVUS, so we can kind of guide where our needle would be towards the balloon. Unfortunately, we weren't able to puncture the balloon with the needle. It just kind of kept skiving off the side of the balloon. And so this led to our second clinical challenge: is how do you create the AV fistula? Our initial plan of doing the balloon puncture was unsuccessful, so we decided to switch to a snare method. Other methods could include gun sight technique, and we have used this technique in subsequent DVAs. So we switched out the balloon for a 7mm gooseneck snare. We were able to snare the needle and then subsequently passed the 014 micro wire, and then obtained through and through access at this point. We then began angioplasty of the DVA AV connection with a 4mm balloon, and the angiogram following shows that we are having flow through the DVA, but at least on the anterior view, you can see that there's brisk outflow through a GSV collateral. This brought us to our third challenge, which was managing venous shunting and early drainage. In this case, we had brisk flow through a GSV collateral instead of forward flow into the plantar venous arch. We started by trying to angioplasty the venous valves in the arch with a 4mm balloon, and we maintained our DVA. In this case, it's a low PT DVA with a self-expandable covered stent across the fistula, and we sized it appropriately so that it would also cover that GSV collateral. And this was subsequently post-dilated to 4mm. And then our final angiogram shows that now we have nice forward flow through the plantar venous arch for the DVA. So an overview of the challenges. The first one was determining what the ideal donor artery would be for the DVA, subsequently creating the fistula, and then managing the venous shunting through collaterals. In our case, we decided to maintain the perineal as a continuous flow, arterial flow into the foot to try to avoid steal phenomenon, and we use the PT as our donor artery. And then instead of our initial method of trying to use a balloon puncture method to create the AV connection, we had to switch to snaring a wire for through and through access, and then managing shunting through the collaterals, angioplasty of the venous valves, and placing appropriate stents is the main way to go. Some key learning opportunities for our team and in general. I think we've done a good number of DVAs at this point, and we found that it's best to have a separate arterial vessel preserving flow to the foot that's separate from the donor DVA artery, and having multiple methods to create the AV connection in case the first one doesn't work, and then ensuring that you have good flow through the plantar venous arch by disrupting as many venous valves as possible, which is now much easier that the lymph flow system includes a valvulotome. Before that, you had to kind of figure out how to do that with either plain balloon angioplasty, or you can use cutting balloons. On our follow-up PVRs, we have good flow into the foot, and then on arterial duplex, we have persistent patency of our DVA with really good flow volumes. At 2 weeks, we had 231 cc's per minute through our DVA. And surprisingly enough, in 2 weeks, he was already showing really good signs of wound healing and granulation tissue. And this was most recently at 10 weeks. You can see that the eschar and the wounds are getting much more smaller, and that he's really having good wound healing. Thank you.
Thank you so much, Dr. Gofur. I think I'll hand it over to Dr. Vasquez and Dr. Jun Lee. I also have a question, but we'll go in that order. And Dr. Shishehbor, anyone?
Ekramul, that was a very good presentation. Thank you. Just out of curiosity, the covered stent was a Viabon, I'm assuming?
Yeah.
And was that an 035 or 018 platform?
We use 035.
Okay, and then I also assume that the lymph flow wasn't available during this in your institution, or
it was not. It was I want to say like 2 weeks before we got lymph flow.
Gotcha. It's interesting. You probably
we did like
$1,000.
What's that?
You probably saved a significant amount of money in doing it the way you did.
Especially since we used a low posterior approach
Yeah.
for sure.
I think so. What do you think made the difference? In January, you couldn't recanalize the posterior tib, and then in April, you became a master. What was the difference?
I don't want to say that we got lucky, but I think sometimes, coming back at different times may kind of help. We did try a different wires that maybe we didn't really try previously.
I think that's a good point. I think for the other guys too. It's just because sometimes it didn't work before, and especially if it wasn't you that was the operator, it's always a good idea to try again, a different approach, a different wire, and you'll be surprised sometimes you can be more successful than not. So I applaud your persistence and good case.
Dr. Gofur, I have a quick question for you. That was a very good way of redirecting flow from the GSV to the plantar vein. Now, you guys have had a great experience with DVAs, and we have had not so much, but I was thinking, how do you decide when to embolize competing venous flows so that you can direct? Do you guys do that at all? And Mehdi, June, you can jump into, and Javier. This is just a question because this was interesting how the covered stent actually helped close off the flow into the GSV and redirect it towards the plantar veins.
Sure. I think when we create these DVAs, you want to manage the venous, and you want to try your best to have forward flow into the plantar venous arch. Is it always necessary to take care of all the venous collaterals? I don't think so. But I think in our case, especially when we did the initial angiogram, we saw a very small wispy flow into the forefoot and almost all of it shunting through the GSV. I think if we couldn't find an appropriate size stent, we may have had to go and coil off that collateral for sure. In this case, it happened to be that our stent, between our puncture and connection between the AV fistula and where that GSV was coming off was pretty close. So we were, in this case, able to take care of two problems with our one stent. But definitely, if it happened to be that it was much further, we may have had to either extend our stent or go in and coil it off.
Thank you. Thank you. Mehdi, any questions? June, any questions?
There's just a couple questions. We're calling this the octagon. So you're not going to come inside the octagon and just get out, easy. So good job presenting. You did a great job. Some questions and some things for you to think about, and also for our audience. Obviously, we want to, have some teaching and learn from each other. I'm worried about this case in a sense that I'm not sure how much if the DVA is even open now, and how much the DVA is helping, because even the peroneal, which was a short stenosis, was going down repeatedly, and you had a 30-centimeter occluded PT, and these DVAs go out when the inflow is not great. So doing a distal PT recanalization, I mean, the technique was cute and nice, but the idea that the PT will remain open for a long time and provide the inflow to the DVA seems to be not realistic. I mean, I think you did the work and you put the Viabon anyway. Why not do it proximal PT, given that it's CTO anyway, and at least give you a little bit more longer patency, because now you have two issues in your hand. One is the DVA itself and keeping that patent, which is usually not the main issue, but more importantly, the inflow. And along that long segment, if you get any kind of a restenosis or disease, that DVA will probably shut down. So I would say that's one thing that I would say I would take into consideration. I think this is a very nice technique for people that have below the ankle disease, like they have a very nice juicy PT, but then somehow because of burgers or other things, they have below ankle disease or distal tibial disease. I think it's a very nice technique, and in those patients works well. But when you have a lot of disease proximally, sometimes it gets to be challenging. But the pictures speak 1,000 words. The wounds were healing. We don't know if it's from the peroneal or from the DVA or from whatever it is. But anyway, it looks like the patient is doing well. The other thing I would say is that heels in general, at least in my experience, and also from the trials, from Promise 1, Promise 2, and Promise 3, heel wounds don't do great with DVA because, as you said nicely, and as you showed nicely, we try to get the flow to the distal foot. So we have good experience, obviously, with toes and TMAs and those kind of things. But heels, there's not a lot of great experience, honestly. At least I haven't seen it in the trials, the 3 trials that we conducted. So I wonder if the pronial is helping at least the heel wound, because you did a good job with those DESs in the pronial and you preserved the pronial, which I thought was very important. So congrats. I think that overall, preserving the pronial was a good point, and you did a great job of presenting the case.
Thank you very much. I appreciate it.
Great presentations. We'll move on to our next presenter, and it'll be Dr. Gordon Wong from University Hospital Harrington Heart and Vascular Institute in Cleveland, Ohio, and he's going to talk about acute limb ischemia and occlusion of a stented femoropopliteal bypass graft. So interesting. So over to you, Dr. Wong.
Thank you so much, Dr. Banerjee. I hope everybody can hear me okay and see my screen. Thank you, everyone, for having me today.
You're good. You're set.
All right, thank you, sir. All right, so yes, I'm going to present a case that I took part of recently. So we'll just jump right into it. I have no disclosures. Our case involves a 77-year-old woman with history of coronary artery disease, prior CABG. She has extensive peripheral arterial disease history with multiple prior right lower extremity bypass grafts, CKD stage 4, and she's coming in with 5 days of severe rest pain involving the right leg. Her initial exam was notable for absent pulses in the right foot with modeling of the skin. And she had a Rutherford class 2A presentation. She had intact motor function of the right foot and toes with intact sensation. At baseline, she has anemia with hemoglobin of 7, and in accordance with her CKD, her GFR was around 16. Her presentation took place in the context in which she had a recent laminectomy about three weeks prior. And unfortunately, that was complicated by an upper GI bleed. And so before her laminectomy and through up until resolution to 2 weeks after her GI bleed, her usual antiplatelet and antithrombotic therapy, Plavix and Xarelto, were on hold. I want to highlight her prior vascular history because I think it's very important in her particular case. As I mentioned, she had 3 prior FemPop bypass grafts, of which the remaining one, a PTFE bypass graft, was the last remaining conduit. In addition, that PTFE bypass graft had prior endovascular interventions as well. There were multiple overlapping Viabond stents extending from the right common femoral artery through the bypass graft down to the TP trunk. And then in addition, there was a Megatron drug-eluting stent in the TP trunk. And in reviewing her prior records too, we know that the left common femoral artery from prior procedures were also occluded. So when she presented, this was her baseline AVI. As we see here, she had very poor Dopplerable signals, essentially no perfusion to the affected limb. And when she got into the emergency room, she had undergone a CT angio. The CT angio essentially highlights that bilateral CFAs are occluded. The right-sided PTFE graft is occluded all the way down to the touchdown point, where and thereafter, after the touchdown, the right anterior tibial artery, there is some signal of possible recanalization, but altogether a very severe kind of grim scenario at hand. So here we're faced with the clinical challenges and taking a look at how are we going to care for this patient? How are we going to help her? Any procedure, any surgery, any intervention moving forward would be a high-risk procedure. The patient's, accounting for the patient's frailty and her extensive complex vascular history. The alternative surgical option that was discussed with our colleagues was involving a right above knee amputation. And in the event that that wouldn't heal, that would ultimately perhaps lead to a hip disarticulation, which would be a very severe, very severe challenge for her. As I mentioned before, we were looking at very limited vascular access options for any endovascular interventions. Both of her CFAs were occluded at this point. And last but not least, her renal function, we would have to be cognizant of how much contrast we would give for any endovascular intervention. But we decided to proceed and help her, and this was a big undertaking. I don't want to understate that. Our case started off with very difficult vascular access because we couldn't go antegrade from above and we couldn't go up and over from the left side. we went retrograde from below. We attempted to access the right anterior tibial artery since that was what the CT suggested had possible recanalization. Unfortunately, despite multiple attempts, we couldn't find ourselves in any meaningful arterial space right off the bat. We attempted to puncture closer to the area of the TP trunk, trying to get into more proximal area of the anterior tibial artery. Again, we couldn't find ourselves in a very meaningful space to be able to work with. Thus, we made the decision to perform direct stent puncture of the stented PTFE graft. And we wanted to go towards the foot to address outflow. And we got a little excited. We didn't actually save our puncture, but here you see that, our wire is intraluminal. It's within the stent. And we perform contrast injection that shows the occlusion beyond the area of the Viabond stent as it's going into the Megatron stent. We're able to wire the lesion effectively with an 018 wire. And as it goes through, we're able to deliver a 3/0 by 150 balloon, performing balloon angioplasty into the right anterior tibial artery. This is an angiogram of our runoff afterwards. We get nice outflow, but we still notice that there's a little thrombus just distal to the Viabond stent going into the anterior tibial artery. So we exchange our 018 wire for an 014 Spartacore wire. And at this point, we are working sheathless. We managed to luckily slip in a 35 by 48 Synergy drug-eluting stent through down to the area going into the right anterior tibial artery. Our stent connects from the previous Viabond into that right anterior tibial artery, and we're able to deploy the stent successfully. At this point, we shift our focus to managing the inflow. Right there on the left-hand panel, you'll see that we're trying to, perform direct stent puncture, but in a retrograde fashion, we're trying to access it inferior to our previous arteriotomy. But it wasn't easy. We tried, but we couldn't do it. So we stuck above, and we're able to get in. We're cognizant that there's a little distance separating our arteriotomies, but at this point, we take what we can get. We send an 018 wire up. And this is kind of what it looks like at this point. We have bidirectional direct stent puncture, and we have accesses going antegrade down the foot and retrograde up the thigh. And we're in a good position at this point. In this panel in the middle, we follow up our wire with a microcatheter. And this frame here, I just want to highlight the extensive amount of Viabond stent that was placed through the PTE graft all the way up to the right common femoral artery. And our injection up here shows that we do have an occlusion pretty much right at the origin of the proximal Viabond stent. So we perform balloon angioplasty of this entire segment all the way to our superior arteriotomy. And we take an angiogram. We see that there is inflow now. We notice that there is some segment of thrombus between our arteriotomies. And as we look back up again, we see that in that proximal portion of the Viabond stent, there's still thrombus there. And that's something that we have to address. We need to take care of this inflow disease. And so we send up a we're able to put in a 6 French sheath, and we send up a 6/0 by 80 Alluvia stent. And we stent at the right external iliac, overlapping with the prior Viabond stent. I think, again, we got a little excited. Unfortunately, we didn't save the screenshot of the actual stent in place, but believe me, it is there. We take another angiogram, much better flow coming down. And as we follow that flow down to the foot, we do see that there is some distal embolization of clot going down the right anterior tibial artery. So we turn our direction to focus on that. From our inferior arteriotomy, we deliver a 3/0 by 150 balloons going down the right anterior tibial artery, and we perform extensive balloon angioplasty of these segments. This is a kind of picture of the runoff that we're looking at afterwards. There's better outflow. The outflow does slow down as it's going down the right ATA. And again, we're cognizant of that region between the arteriotomies, that there's some residual clot that needs to be dealt with there. And so the best way to deal with this, we felt, was, we have to go retrograde. We have to go lower. Fortunately, because we have a wire down in the anterior tubular artery, we're able to gain fluoroscopic guided access into the vessel. We're able to send a wire up. And our final intervention that we did is we take we took a 5/0 by 120 balloon, performing balloon angioplasty of this segment between the arteriotomies, treating kind of that inflow, that mid-segment inflow disease. And this is our final angiogram here, which shows much better flow downstream. The patient did well afterwards. There were no procedural complications. On post-op day 1, the patient already had warm lower extremity with Dopplerable pulses. She was resumed back on her oral Xarelto. She had a successful recovery and was able to be discharged from the hospital on a regimen of aspirin, Plavix, as well as Xarelto. When I reflect on this case, it was a big undertaking, but I think kind of the major things that I learned from this case is even when there are no options, sometimes we're forced to create an option that will give the patient the best chance to recover. The second thing I learned from this case is the final result doesn't always have to be perfect. We strive for perfection, but if we can get the patient to a reasonable state, give them time, give them good medical therapy, sometimes those are the things that can help the patient heal. The last thing that was emphasized in this case is to be adaptable and to be persistent. Utilize, multiple access sites to take care of the patient. Utilize things like direct stent puncture and be prepared to work sheathless. Just have a quick follow-up. Dr. Shishehbor and I, we just saw this patient just 2 days ago in clinic. She's doing well. She's without pain. Her foot's looking great. These are her ABIs. Just a fantastic change. And she was very happy. This is just a closing picture of, of something that I took with her in clinic. Overall, great result. Thank you.
Great presentation, Dr. Wong. Over to our panelists. I think we have a select. I just want to add that there are over 40 attendees to the webinar, and we'll invite them soon to ask questions and share their comments on the cases too. So I have one question for you, Dr. Wong. So the first antegrade access of the vein of the graft down to the below the knee segments, then the puncture above. Was it your thought that that guide wire that you had placed into the foot through the AT, couldn't that have been done much sooner? I was expecting, rather than try to puncture the graft above.
I think I understand what you're saying. Please clarify if I'm wrong. You're saying after we had kind of gone antegrade and gone down, it would have made more sense than at that point to go kind of just retrograde to go up.
Yes.
Yeah.
Exactly.
Yeah. I think I think in hindsight, I think, Dr. Banerjee, that may have been that certainly would have been an elegant and, way to do it. I think in the moment when we were working, we struggled very much with access at the very beginning, and we had found an access approach that had worked for us. And so we kind of just wanted to continue that momentum therefore, but you're right. I think technically,
I also
yes.
think that one of the reasons that your possibility of actually recanalizing inflow would have been not as good from the foot. I do agree with that. So maybe that was the right approach because you needed to establish very good inflow into this system. So great case, great, well presented, and very thoughtful.
I have to jump in here. I think of maybe being the only surgeon on the panel. So did you speak to the vascular surgeon before embarking on this adventure?
Yeah. We had actually, I think, our team were in discussion with the vascular surgeons. We typically have what's called, a limb salvage committee that kind of discusses these patients in full, before we take any action. And so it's very much a multidisciplinary discussion up front to kind of figure out what's the best course of treatment, for these patients. And so this was done in a collaborative approach in which, we all got together, we're able to kind of discuss pros and cons of the approach. And, what we realized is that in this situation, every path forward would carry risks of its own. And, we felt that let's give this a shot. Let's see what we can do to try to help the patient and see if we can save her leg this way.
I think my only criticism is they probably led you down the wrong path. So surgical bypass grafts, they don't occlude with atherosclerosis. And they always occlude with thrombus. So you were doomed from the start to have embolization. So a better approach, maybe, I liked your creativity with this approach, and I actually agree with it, but a small cut down directly on the graft for access would have probably saved you a good hour and a half from an access standpoint, and also would have allowed open thrombectomy with a simple Fogarty to get rid of all of your thrombus, and you wouldn't have embolized, and then you could have treated the areas that really were just athero, which were the common femoral and the outflow. So that's something that's very important to remember. The reason your wire passed through that bypass graft so easily was not because you're a master of wires. It's because, and I tell this to our fellows all the time, if your wire goes through a blockage really easily, it's not because you're great, it's because that's thrombus. And you have to know that. That will save you so many times in the future. I think that's a very important takeaway from this case. If you would have made a very small cut down above the popliteal or even in the groin, that would have removed all of the thrombus with one simple pass to the Fogarty, and then you could have treated everything, and you probably would have saved 2 hours and no embolization. Something to consider, but good presentation.
Thank you.
Excellent. Excellent. Comments, June, from you and Mehdi? I know he's your student, but you can always comment.
I think this case really illustrates the importance of persistence. I also know this patient well, so I don't necessarily want to bias any comments either. I think one criticism potentially, or question, Gordon, if you may, is why not consider using brachial access? Seeming that there is no CFA access sites in this patient with brachial, consider what are the pluses and minuses of potentially using a upper extremity approach.
I think the upper extremity approach definitely is possible. It's a viable approach, but I think one of our concerns was, depending on how far down we would have had to go, especially below the knee into the tibial vessels, if we needed to perform something like thrombectomy, I think there's some length limitations, if I recall correctly, that might be, in delivering certain thrombectomy devices, just those length limitations might hamper delivery and utilization of some of the equipment. That's, other things like support and.
I think in the interest of time, we are going to move, and I just want to make sure that, Tom, you can extend the webinar time so that we can give Dr. Ahmad Younes from ProMedica adequate time to discuss an important topic. There are options, very well stated. And also I invite the attendees who are on this webinar, hopefully you're enjoying it, but you can put your comments and questions into the chat box. And of course, feel free to opine which presentation you would like, and you will be asked to vote soon. So Dr. Younes, over to you, and thank you for presenting today.
Well, good evening. Thank you for having me. I have no disclosures. So I'll be presenting a case of a 50-year-old male with non-healing left foot wounds. His past medical history is complex past medical history that include hypertension, diabetes, prior stroke. He's got a history of coronary disease with prior CABG. He's actually end-stage renal disease, previously on dialysis, now status post-kidney transplant. His creatinine is 1.5 around baseline. He's got a history of left, second, and third toe amp in 2020, prior SFA stent. His social history, importantly, includes developmental delay, but he's independent. He lives with his sister, so he's pretty functional around the house. He underwent left lower extremity angio, and intervention attempt at some point got complicated, unfortunately, by popliteal artery dissection, and that is his wound appearance. So there's the left big toe and the fourth toe ulcers that have been non-healing. So he got referred to our office. His non-invasive testing is non-compressible vessel calcified, likely with posterior tibial and dorsalis peris artery Doppler waveform that is monophasic, abnormal PPG waveform at the ankle, and flat at the toe that was measured. So we agreed with this patient. We took him to the lab. Antegrade common femoral artery access on the left side. His SFA stent is patent, but his popliteal artery has severe disease. In the below knee segments, there is severe osteoproximal left anterior tibial artery, stenosis, TP trunk disease. His posterior tibial is actually occluded, and a lot of below ankle diffuse disease and calcified vessels. So we're able to cross his popliteal artery stenosis, angioplasty with an 018 command, angioplasty with a 5540 balloon, and then we turn our attention to the below knee segment at this point. Sheath was advanced, trying to minimize contrast here, given his kidney transplant and elevated creatinine. Underwent angioplasty for the TP trunk 4x40 balloon with improved lumen size, but also his anterior tibial artery with moderately improved angiographic improvement. At this point, the popliteal artery underwent angioplasty with a drug-coated balloon and finished with a Supera stent 5.5/60. His foot flow improved, but I was still worried about his forefoot flow past the midfoot. Followed this gentleman in clinic. He's got, yes, improved Doppler waveform at the DP and the PPG waveform at the ankle, but his wound actually did not improve, which was unfortunate for him. So at this point, we did discuss him in our limb preservation board, which included the patient podiatrist and actually a multidisciplinary committee where there was multiple podiatrists, vascular surgeons, interventional cardiology, and the wound care. And given his complex social history and the length of the duration of his wound, especially in the setting of his immunosuppressed status with the kidney transplant, and the social history where going into worsening wound and amputation may be debilitating for him, particularly with his social history and dependence on his family. So thought was to evaluate him for DVA at this point. So we did our vein mapping. We took the patient to the lab again with ultrasound guidance, obtained access at the lateral plantar vein, inflated a cuff at the calf level, and angiogram. Here I was a little bit worried about the venous pedal arch, but based on ultrasound, I suspected the sheath is probably maybe occlusive in this spot, or there's a valve that we did appreciate. Integrate access in his left common femoral artery, obtain his popliteal artery stent is still patent, but interestingly, there was a good amount of recoil, which is not surprising, in his recently treated segments in the osteoproximal AT and TP trunk. From there, I thought we should certainly optimize his native arterial circulation. This was treated at this point with some kind of calcium modification technique with intravascular lithotripsy for the TP trunk and the anterior tibial artery, with the goal is to improve his native arterial flow, reduce some ischemic rest pain, and reduce some of the early steal phenomena that can happen with his DVA. The challenge that we had at this point is accessing his posterior tibial artery. Used multiple catheters, coronary supercross, modified a JR4 IMA catheter, command wires fielder. The floppy wire that would able to wire the proximal PT gets hit by the proximal occlusion. Catheter is not supportive enough, and if the catheter is supportive enough, the wire was not crossing. So we had a lot of challenges wiring his native posterior tibial artery given the angle that was there. So at this point, did obtain, so we have an 018 command wire that is in the posterior tibial vein that is present. And here with fluoroscopic guidance, I performed a dry stick on the posterior tibial artery and advanced an 018 command. The command would go, but an 018 wire would go, but no microcatheter would follow given the extensive calcification and occlusion. I ended up putting a sheath in the posterior tibial artery 4-5 slender, exchanged the wire to an 014 system, and slowly serially dilated the posterior tibial artery with coronary wires. With coronary balloons, other balloons would actually not cross despite having a sheath in place. So have to rebuild the posterior tibial artery, which eventually was able to penetrate the proximal cap and externalized through an antegrade navicross and created the first rail and performed angioplasty for the posterior tibial artery with the goal to deliver the reentry device to proceed with the DVA. So I don't have the full fluoro saved, but we use the lymph flow device with a V-siever coming from the vein and the arc arterial catheter from the proximal posterior tibial artery. It was not a difficult puncture. We're actually able to puncture straight in the V-siever, captured the wire, and here created a second rail through arterial into venous system. Balloon dilated the AV fistula with a 4 by 40 balloon. That's the angiogram after dilating the fistula. It did advance the valvulotome that came with a lymph flow kit. Nonetheless, I typically do a 5 millimeter long balloon just to test if there's any recalcitrant valve, so not to get into a valve regret situation. Still, there was a lot of waste on the balloon, and I did use a coronary cutting balloon, Wolverine, which successfully was able to lyse this valve. From there, deployed with a 5 millimeter stents, the covered stents, and eventually with a tapered crossing stent 5.0, 3.5 into the posterior tibial artery. Despite this angiogram, I was still worried about the proximal posterior tibial artery and the TP trunk. I imagine that would be the Achilles heel for should this graft or DVA decide to go down. So eventually extended it with coronary 3.5 by 38 stent into the TP trunk and post-dilated it with 3.5 coronary non-compliant balloon and 4.0 in the proximal segment. Then we turn our attention to the below, down to the tibial, to the plantar vein, which I was able to recross, balloon angioplasty. And here's the valve that I was suspicious that we were dealing with, which was treated with cutting balloons and balloon angioplasty. Angiogram noted improved flow. Excuse me, the angiograms are playing fast for some reason, but the flow to the foot it did improve, and we do see early some metatarsal vein that are opacifying here. So this patient was followed closely in clinic. We've had a lot of conversation with the podiatrist to try to delay his surgery as much as we possibly can, and avoid the temptation to proceed with surgery early until the DVA matures. Eventually ended up with a first toe amputation, and he was followed closely in clinic and eventually healed, and he's now walking with no issues. Thank you.
Thank you very much. That was a great case and a lot of steps and a lot of thoughtful deliberations here. So over to our panelists. Mehdi, you didn't ask a question, the last one. Please go ahead. Maybe you should start.
No, great presentation, Ahmad. Very thoughtful and very carefully done. In my opinion, and I like the fact that you even extended the proximal DVA with the DES into there, because as I said earlier, these DVAs, they go down from inflow disease, and these patients with immune suppression, in my experience, they're the worst. Even if they have great blood flow, they take a long time to heal because of the immune suppression. So I really don't have any other comment.
Javier and June, comments, questions?
I think the key word on that case was thoughtful. I mean, it really showed your thoughtfulness to it. We can all fall into that trap where the picture looks okay. It's been kind of a little bit of a case, and you've gotten crossed over. You're happy, you move forward, and you weren't happy with that result, and you were thoughtful enough to extend proximally, and I think that helped you a lot. I also liked your idea of going in, even though you passed the valvulotome, not taking it for granted and checking it with balloon. I think that's a good idea with these DVAs. So good case. I don't see any really criticisms for that case.
Ahmed, one question. Can you identify with intravascular ultrasound valves, residual venous valves?
I do. I have actually IVUS previously a vein prior to deploying stents, but I still found veins when I IVUS them. But then when I balloon angioplasty them, there was actually no waste. So even though I see the findings of these veins on IVUS, I'm not sure they're competent enough or not to prevent stent expansion.
So the best way is to balloon them and use a cutting balloon and make sure there is no waste.
Yeah.
That's a good point, good learning point. June, comments from you?
No, I echo the other panelists' comments. Really masterful presentation in case.
So we're going to take about 3 minutes. I would ask the attendees to probably turn off your cameras for a few moments. We will deliberate here. There is going to be a poll that is going to be passed over to the attendees. There are about over 40 attendees, and we will, you can just send me by email or text your scores for each of the applicants of the presenters between 1 and 10. And I'll pass it on to Mehdi, my dear friend, who loves to announce and give out the gifts. But he'll make the announcement today of the winner. But this
the only reason I come on this show, man. That's the only reason I'm here.
What is it?
Only contribution to announce the winner. I agree with you.
That is it. That is it. We are going to spend your money, Mehdi. It's okay. So please text me your scores. I think we each have to abstain for one. So we'll take the best of 3 of each of the presenters. I also request the attendees to please send your votes, please, and your poll, and respond to your poll, and that would be amazing. Kelly, can you help me tally? I have the judges, and I'm looking at the responses from
I
the
think it will come up,
panelists.
Subhash. I think the poll is going to come up at some point. I
Yes.
think Tom and Kelly are going
Yes,
to show us.
I think based on our judgment, I'll pass it on to Mehdi and text him so that he can make the announcement. I'll put everybody on this text
Yes.
for a second.
I think we can show it, Kelly and Tom, if you guys want to show the poll, we are very transparent here. We have, this is really more for education than anything else, to be honest. This is not, for, any gimmicks here. And, we encourage people to submit cases and, we try to get as many cases, and we obviously want to encourage our own fellows to also submit, because it's all about learning and taking advantage of the opportunity to hear each other and go back and forth and so on and so forth. So listen, I think you see the data. Dr. Ekramul Gofur is our winner here. He got 43%. He did it by a lot, so that's great. I think he did a great job with his presentation for sure. And I think, if you agree, Subhash, I think we all learned something.
We learned tremendously.
Definitely learned that next time our vascular surgeons say above knee amputation, I'm going to have him call Javier so he can tell them to do embolectomy because, but that's my take home message for this meeting. But, we all learned something, and it was great presentation by all 4 fellows, in my opinion.
I can tell you this has been a very, very tough one, because I myself, I think the audience has done a great job parting it out, but I want to congratulate Hector, Ekramul, Gordon, and the Dr. Ahmad for wonderful, thoughtful case presentations and selecting and demonstrating that CLTI options are now mainstream and interdisciplinary collaboration and partnership is the way to go. So, and I want to acknowledge my partner. I know I want to brag about him, but Mehdi, I think this has been one of your greatest contributions to this, to do the DVA trial. I personally was very pessimistic, but I can see now how it has transformed and continues to transform our landscape of CLTI patients. So thank you very much to each one of you. Mehdi, final words from you, and then we will close.
No, please don't submit cases to these octagons. Again, it's not so much about winning. It's fun to win. I get it. It's $500. You're gonna have to take Dr. Gofur. You're gonna have to take the cath lab out.
That's right.
With $500. I don't know. In Miami, that's not a lot. That may get you bread and cheese. You're not gonna be able to buy steak with that in Miami. But seriously speaking, I hope that you encourage your colleagues to send cases, because that's the only way we learn, by seeing cases, see how people do it and different techniques. And that's just, that's great. And thank you, Subhash. And I want to also very grateful to Dr. Vasquez and Dr. Lee. I know it's late at night, Thursday night, and probably both have to be at work tomorrow. So very grateful to everyone, all of our attendees, our team back there who are, doing all the work. And hopefully we see you all soon next month with the next Octagon. And don't forget, CVI 2026 in August, Denver, Colorado. Thank you so much. Thanks, Subhash.
Thank you. Thank you, guys. Thank you so much, Mehdi.